even travelled in a high-risk area is asked not to donate blood for 6 months after his return. And finally, as The Guardian recently reminded us, an increasing number of countries now require long-term visitors to be tested for HIV antibodies before they enter. And however doubtful this practice may be, it's usually much safer to have this test done in Britain before departure than with a dubious needle on arrival.
Nighttime is a time of danger for the stomach. This is when acid, unbuffered by food, may damage the mucosa.
Axid 300 milligram heals ulcers by controlling acid through the night, and then has the benefit of allowing a return to near normal gastric function during the following day.
Axid 300 milligram lets ulcers heal by night and the stomach work by day.
Hello and welcome to this edition of Pharmaceutical News Desk, a service sponsored by participating companies to give brief, factual details of new drugs, new indications, prescribing information and services. Merck's new pancreatic enzyme preparation, Nutrizyme GR, for the treatment of pancreatic deficiency state, especially in cystic fibrosis, is now available from pharmaceutical wholesalers. It is formulated as uniform gastro-resistant mini-pellets in gelatin capsules and has a high guaranteed potency of pancreatic enzymes. That is 10,000 BP units of lipase and amylase and 650 BP units of protease. Further information is available from Merck Limited at 4 Marks, Alton, Hampshire. The telephone number 0420 640 11. Ledderly would like to announce some good news for all ears. The good news is that 3-drop Ordicort not only contains an antibacterial and anti-inflammatory component to ensure effective treatment of otitis externa, but also Ordicort comes in a clear, oily solution. This avoids crusting and enables the doctor to view inside the ear at subsequent examinations. To help you see the difference, write to Jonathan Odie at Ledderly for a free reusable pen torch. Jonathan Odie, Ledderly Laboratories, Fareham Road, Gosport, Hampshire, PO 130AS. And that's all for now. Prescribing information appears on an accompanying sheet. Join us again next time for Pharmaceutical News Desk. Goodbye.
Zantac 300. 1 tablet nightly for healing ulcers.
In this section of the programme, we'll be seeing the start of our new series of minor surgical procedures in general practice. But first, the bmtv diagnostic quiz from who else but Dr. Hilary Jones.
This diabetic patient presented with an 18-month history of progressive weakness in all 4 limbs, accompanied by fasciculation in the affected muscle groups.
Can I first of all ask you how old you are, Mrs. Mitchell?
I'm 64.
And what was it that first caused you to go and see your doctor?
Sort of a whirring sound in the car, feeling in the calves of the legs. And I noticed that I wasn't walking as I should do.
Are there any other things that you feel it's difficult to do?
Well, everything. I can't do my own hair. Can't undress myself, can't get out of a chair. I just can't do anything.
Can you manage stairs?
Not now, no.
Has it affected your speech or swallowing?
Well, it has done a bit, and it has affected my speech.
In what way?
Well, talking to you, I'm finding it difficult.
Mm-hmm. She had no sphincter or sensory disturbance, and there were no signs of bulbar or pseudobulbar palsy. Her diabetes was well controlled, and her higher mental function was normal. Now I want to test the strength of your muscles, particularly in the arms and legs. To start with, can I ask you to grip my fingers as hard as you can, with both hands. Grip as hard as you can, and push me away from you. Push. Good. Pull me towards you. That's good. In fact, all muscle groups generally were distinctly weak, and raising her arms above her head or her legs off the bed proved a considerable effort. Her reflexes were very brisk throughout, and there was clonus at the wrist. Plantar reflexes were upgoing on both sides. There was evidence of fasciculation generally, but most obviously in her case at the elbow. The following investigations were carried out and were normal. However, nerve conduction and EMG studies revealed lower motor neuron abnormalities with fasciculation in all 4 limbs. There was little the medical profession could do to help in her case, but the provision of various aids certainly made life more bearable. For the quiz this month, we'd like to know, firstly, the diagnosis. Secondly, what is the significance of the absence of sensory and sphincter involvement in this patient? Thirdly, at what age is this condition most common? And lastly, what benefit can this key be to the patient and to other patients like her?
And the quiz answers appear, as usual, towards the end of the programme. Now, next we have the start of a new series, and one which is actually quite topical, Bill, isn't it?
Yes, I think the government's recent white paper on the future of general practice makes it very likely that GPs in the future will get some additional remuneration for carrying out minor surgical procedures in their own practices.
And that in turn should help reduce the hospital waiting lists for minor surgical procedures like that.
Yes, and hopefully it will. Of course, there's no substitute for hands-on experience, but what we're trying to do in this series is to pass on the experience of one GP who's carried out a very large number of surgical procedures in his own practice. In fact, well over 5,000 minor surgical operations in the past 15 years. What we've done is to go to Dr. John Stuart Brown in Larkfield in Kent, and we join him now looking at the use of electrocautery in general practice with his heels.
And this is the lesion now exactly 4 weeks later, and you can see it's nearly healed. It would have healed a little quicker had we excised and sutured it, but it's perfectly satisfactory using the electrocautery, and a few more weeks and the scar will be virtually invisible.
That all looks very simple and effective. Presumably the electrocautery has quite a range of uses.
Yes, and I'm sure we'll be seeing it again incidentally later on in the series.
How much does the equipment actually cost?
Well, with the tips we've seen there, around about £250.
And of course that's not reimbursable at present.
No, it's not. I think at the moment minor surgery in general practice is largely a labour of love, although there are some ways to get some reimbursement for some of the things, the costs that you incur, with clever use of the Red Book, and we'll try and take a look at that later in the series.
What procedure's coming up next month then?
Next month we're looking at a particularly effective way of dealing with ingrowing toenails by wedge resection.
Judging by the number of people who complain about those, that's something to look forward to. After the break, we'll be looking at the diagnosis of vertigo.
Mastery of the airways. Yesterday, today, and tomorrow. Ventolin. Not all little cowboys can handle cow's milk. And it's for them that Wyeth developed Y-Soy, a soya infant formula. Because by making it as nutritionally complete as standard formulas, Y-Soy provides everything a growing baby needs before moving on to solids. That's why over the past 6 years, Y-Soy's helped thousands of little cowboys grow up to be big cowboys.
all the joints in all the world. You came into mine.
You look as though you could use a stiff drink.
After taking these blue babies, you can forget the stiff.
Hey, boss, that's my tune.
Zantac 300. 1 tablet nightly for healing ulcers.
We're now going to explore the idea of complementing a written account of a clinical problem with a television review of the same area. Bill, you're a former editor of Update and other medical journals, and I know this is a new approach you're particularly interested in. What's the aim here?
Well, I think clinical review journals have a very important place in continuing medical education, but I know from my days as an editor that there comes a point in a lot of articles where what you really need to demonstrate is very difficult to demonstrate in print because it involves movement or other procedures, for example.
So what's the plan?
Well, the plan at the moment is that Update are running a very good series of articles on the clinical examination of patients with a range of different problems. In the issue of May the 15th, they're running an article on how to examine a patient who comes complaining of vertigo. And what we're trying to do is to look televisually at the various procedures involved in that examination.
So this is a feature specifically designed to be viewed in parallel with the written article in Update?
That's right. Update, May the 15th, 1988.
So we go over now to Dr. Paul Stillman in conversation with Dr. Eric Gambrill.
What's the presentation of this case?
Young man who comes in having a few days before had an acute unpleasant episode. He wasn't seen by a doctor. During this episode he felt giddy, unsteady, a bit of ringing in his ears and nauseated, didn't actually vomit but felt sick. And he said that when it came on, it was bad enough to make him sit down. He actually lay down for a while, for half an hour or so. And the episode gradually passed off, and within 2 or 3 hours he was fairly well better again. On direct questioning, he said that he'd had a bit of ringing in his ears, and he wasn't sure about hearing loss. Just on that very bare history alone, what would you think of as the most likely possibilities?
Well, I suppose the commonest would be labyrinthitis, epidemic vertigo, and benign positional vertigo. After that, possibly Meniere's disease, of course, epilepsy, and possibly migraine.
And then, of course, I suppose at the very back of your mind, and I think you've got to work all the time in terms of probabilities in general practice, and these are very low probabilities, but you have to have them in the back of your mind, things like brain tumours, acoustic neuromas, multiple sclerosis, I suppose an older person, some sort of brainstem ischemia.
So, within the constraints of the time, then, what tests are we going to do to try and differentiate a few of these?
Because of the association with hearing loss, tinnitus, that sort of thing, I think it's useful to check the hearing using the tuning fork, and a very simple test take a few seconds, really.
The use of the tuning fork in the examination of conductive and perceptive hearing defects was covered in detail in issue 52 of bmtv. Nystagmus may also be assessed with the patient sitting. It may be spontaneous or be induced by following the examiner's finger to about 30 degrees up and down and to both sides. Finally, Hallpike's test reveals benign positional vertigo. The patient sits on the couch and turns towards the examiner. Supporting his head, the patient is quickly laid down with his head over the couch 30 degrees below the horizontal. The test is positive if nystagmus is observed in the next 30 seconds.
You certainly want to look in the ears and see if there's any sign of local ear disease. I think if you can be happy that you can draw a negative on those 3 things, then against the background of a young man with a single episode, that would probably be enough to satisfy me, unless something else turned up surprisingly in the examination.
After examining both ears, the gait and stance are observed to check balance. Romberg's test assesses stability.
Okay, John, can you put your feet right close together? Okay, right, just stand still, just look up at me, right, okay? Now can you just close your eyes? I won't let you fall. Okay, open them again. You're obviously quite stable doing that. Can I ask you just to spin round a couple of times and then come back to the same position? Right. That's right. And feet together again, head up again. Close your eyes now. Right, that seems pretty stable. Okay, fine. What we're looking for here is just the ability of someone to maintain the balance. It's much more difficult with the eyes closed to keep the balance than it is with the eyes open. And so it's a test. In fact, he was extremely stable throughout the test. You couldn't have done that a couple of days ago.
Anything else we should be thinking of?
The blood pressure is worth checking, I think, particularly an older person, partly because it's an opportunity for opportunistic screening, but also it might give you some clue as to vascular disease and I suppose the possibility of minor stroke or TIA or something like that.
Okay, so what conclusions have we come to?
Well, here we have a young man with one episode of what seems clearly to be acute vertigo, self-limiting, associated with a bit of tinnitus, and I had a sensation of maybe a slight degree of perceptive deafness on that side. Now, I think this could all be accounted for by just one attack of labyrinthitis, whatever that is. But in view of the slight doubts, I think I'd want to keep an eye on him, and certainly I'd be more concerned if he was to have recurrent attacks of similar episodes of vertigo.
Thinking of Meniere's disease?
Thinking of Meniere's as a possibility, yes. He's a bit young, but I suppose it's possible. And we thought about all the other possible rare causes as well. My money would still be on a simple episode, but I'd just like to follow him up and be sure.
Dr. Eric Gambrill from his practice in Crawley. Next month, Update will be looking at backache, and so will we. After the break, news of a new initiative from bmtv and the BPMF.
Suffering the effects of dysmenorrhea and menorrhagia is no longer an unavoidable problem for today's women. Ponstan provides a non-hormonal answer by delivering a twofold action against prostaglandins by inhibiting synthesis and blocking tissue response. In a recent study, the average pre-treatment blood loss for 22 patients with unexplained menorrhagia was reduced by 45% following 2 months treatment by Ponstan. Available in a range of easy-to-take, low-cost presentations, Ponstan provides non-hormonal treatment for dysmenorrhea and menorrhagia.
Zantac 300. 1 tablet nightly for healing ulcers.
bmtv has always aimed to provide relevant postgraduate medical education for doctors, principally as an informal but regular video magazine programme. Of course, we've always been confident of the unique place of television in education and are rather proud that we're now able to offer a formal, structured syllabus in collaboration with the BPMF. To preview this series, we joined Dr. Paul Stillman, who's not only a GP and one of our medical producers, but a regional course organiser for the BPMF, talking to Dr. Marshall Marinka, Director of the MSD Foundation and a member of the Council of the Royal College of General Practitioners.
It was a few weeks ago that Professor Paul Grobe announced the British Postgraduate Medical Federation's plans for television programmes expressly for vocational training. Dr. Marinka, what do you think is the value of television in vocational training?
I think the value of all video material is that it gives you another dimension for communicating, a dimension beyond the written word and the spoken word. So often an image can have an enormous impact, particularly in a branch of medicine like general practice, where one's dealing at the same time with disease, with feelings, with the situation of the consultation. So that's one enormous advantage which video has over previous methods.
Do you think it's important that this is a new technology, direct television specifically targeted for trainers?
Yes, I do. I think that although it will begin by being targeted at vocational training, inevitably it will spill into continuing medical education, which is perhaps the most important phase of medical education that we have to deal with. So I think from that point of view it will be enormously innovative and important.
What sort of programs would you like to see?
Right. I think there are two areas that could be particularly exploited with this sort of technology. First, the area of the consultation itself, exploring, for example, the patient's beliefs, the way in which doctors solve problems. Television has a particularly keen eye for looking at that. The second area is the whole world of performance review. And here I think the interactive promises of this technology hold out great hope.
And when we have computer-assisted and interactive television programs, presumably the prospects become much more numerous.
Yes, they become almost endless, because then the learning becomes targeted on the practice itself, how it is performing, what it is actually doing. And that also opens up the possibility of comparison with similar practices. That also can raise questions about quality.
So, in the longer term, do you think the time will come when this technology can provide diploma courses or other methods of assessment?
I'm not a great man for diplomas. I think what's important about education is its creativity and not its control. But yes, what I do see in the future is a coherent program of professional development and medical education, which something like regular broadcasts can help to shape.
Well, in the first year, we'll be concentrating on the acquisition of teaching skills in the main.
So, presumably the programme will be of specific interest just to trainers?
I think it has a broader interest. For example, one of the first topics we'll be looking at is selection procedures. Now, it's obviously very important when you're selecting a trainee to make a good appointment, but we are all involved in choosing partners or appointing other members of staff.
Don't you think, then, that most of us are quite good at that?
Well, I think we are, but research suggests that really we're not. The social chat that passes as a selection interview is really notoriously unreliable. First impressions are almost always wrong, and what we will be looking at is a much more ordered, structured way of going about the selection procedure. A bad appointment can be a disaster.
And what about teaching skills?
Well, there are 2 points I'd like to make. Firstly, I think a teacher should prepare himself. He should order in his own mind how he is practicing medicine. And this is a very good thing for us all to do from time to time. It's quite easy, I find, as a general practitioner, almost to practice on autopilot. And I think I would like to suggest that all thinking doctors might ask themselves periodically, do I have 20 years' worth of experience, or have I repeated 1 year's worth 20 times? The second point I'd like to make is that when we're looking at models of teaching, I think there's a very close parallel between teaching tutorials and the consultation. I mean, the teaching techniques may range from the sort of style of pin your ears back and listen to what's good for you, to let's you and I explore this problem together. Now, this has relevance in the consultation as well as in the tutorial.
And how are you going to cover this on television?
Well, we'll be doing a variety of things. Role play, especially in the use of assessment, which is a new idea. We'll be looking at different tutoring models and skills, and we'll be using the trigger tapes.
Practice teaching, which is what I see trainers being engaged in, has particular difficulties, because the practice teacher has to be able to translate their own experience and knowledge into a clear teaching framework, unlike the sort of rambling anecdotes that often pass for teaching. This happened to me, therefore you'll learn from it. And I suppose at some stage we may have to confront the trainee with our differences in perception. They may think that they're doing extremely well in one area. We may perceive them to be doing not so well and would be looking for improvement.
The crucial part of the trainee year, really, is the curriculum that the trainer and trainee are together going to follow. And in order to know what curriculum you need to follow with a particular trainee, you need to know A, where the trainee is when he or she starts, and B, where you want him or her to be at the end of the trainee year. And this really brings up the dreaded word assessment. If that's done well, we should pick up any really big problems at an early stage and either be able to deal with them and demonstrate by further continuing assessment that they have overcome the problems, or in a very small number of cases, we may be in a situation where it looks as though they cannot be overcome. And in that stage, you're perhaps into career counselling, or maybe saying you ought to go and take up neurosurgery or whatever.
I think that in the very near future there's going to be a change in emphasis on the way that we practice, in that moving away from a doctor-directed healthcare system, it's going to be very much more directed towards what the consumer wants. And this perhaps will be the most difficult area, is to really understand the true meaning of truthfulness. And I think that they will need to have special training to develop those skills.
We'll also be looking at subjects as diverse as the use of computers to that of sexuality. If you think the whole thing's a load of rubbish, or perhaps you've got some ideas of your own, we'd like to hear from you. We're going to run a soapbox. Now, what's in the first programme?
Well, the first one will be looking at the management of the tutorial. We'll be looking at setting the scene, defining the content, looking at appropriate teaching methods, and finally, summarising the educational points.
Give your arthritis patients full 24-hour relief from pain and inflammation. Oravail 200, one a day for effective, well-tolerated relief in arthritis.
There's some good news for women starting the pill. New Minulet from Wyeth, world leaders in oral contraception.
In order to receive bmtv's important new daily news and information service for doctors, you will need a direct television receiver, which will decode our scrambled transmission and automatically switch your video to record each day's programme. Please apply now for your receiver, which is included in an annual subscription to the new service at £40 per year. If you don't have a video, or would like to replace yours with a more modern one, £70 per year provides you with a dedicated VCR with our receiver, and up to £100 will be paid for your old video. Order your receiver now. Either phone your order, quoting your access or Visa number, or use the enclosed Reply Paid card.
The quiz this month featured a 64-year-old lady with motor neurone disease, which had caused a spastic tetraparesis with lower motor neurone signs in all 4 limbs with fasciculation. There is never any sphincter or sensory disturbance in this condition, although the affected muscles can hurt a little just before they become involved by weakness. The absence of sensory signs in this lady makes diabetic peripheral neuropathy less of a candidate for inclusion in the differential diagnosis. The peak age incidence is between 50 and 60 years of age. And finally, what of that mysterious key the patient was talking about?
I didn't realise I could obtain one of these keys for the price of £2, which enables me to unlock any disabled toilet in England.
And that's just about it for this month. Still to come, a brief postscript on the latest developments in ulcerative colitis from Smith, Klein and French.
And before that, a postscript from Ames about the control of diabetes.
But this is where Bill Jackson and I say goodbye until next month. Goodbye.
Bye.
Prescribability of blood glucose test strips is a major step forward in the control and management of diabetes. The great weight of medical opinion points to improved blood glucose control as the best means of reducing the incidence and the severity of the known complications of diabetes, such as neuropathy, nephropathy, and cardiovascular complications, including retinopathy, which is the greatest cause of adult blindness in the UK. The story of the monitoring of diabetes began almost 50 years ago, when Ames developed the first genuine home monitoring test for urine sugar, Clinitest reagent tablets. And this quantitative method is still widely used and trusted today by many diabetic patients worldwide. But Ames technology has continued to advance, and now similar results can be obtained using Diastix reagent strips in just 30 seconds. And speed is seen by many patients as a major encouragement to regular testing. Here's the test procedure. Hold the plastic end of the strip, but do not touch the test area. Dip the test area of the strip into the urine sample and remove it immediately. Then begin timing. After exactly 30 seconds, compare the developed colour against the colour scale on the label. In fact, a very straightforward test to perform. Many of those with diabetes will be perfectly happy to monitor their glucose levels with this very quick and convenient test. And of course, Diastix is prescribable. But those patients who use insulin or have an abnormally high renal threshold have difficulty in achieving tight control with urine tests. And this is where prescribability of blood glucose testing strips becomes so important. The value of self-blood glucose monitoring is especially apparent in conditions such as pregnancy or during periods of intercurrent illness. Ames' latest product for blood glucose monitoring, GlucoStix reagent strips, are rapidly being adopted by diabetics around the world because of their accuracy and ease of use. GlucoStix are dual-purpose strips designed for visual or for meter use. Here's the test procedure. Your hands should previously have been washed with soap and warm water and dried thoroughly. First, remove the end cap of the Ames glucolet. Load the glucolet by inserting a new lancet. Replace the end cap onto the glucolet and press the release button without moving the device. Then gently stroke the finger, forming a large drop of blood. The whole procedure is quick, controlled, and virtually pain-free. To carry out the test, the drop of blood is applied to the test pads of the strip, and the blood allowed to remain for 30 seconds. The blood is then removed from the strip by blotting with absorbent tissue, once firmly, and then a second time on a clean area of tissue if required for complete blood removal. Next, where a visual reading is to be taken, the reaction is allowed to continue for a further 90 seconds. And the developed colour on the test strip is directly compared with the colour blocks on the label. The two colour bands clearly differentiate between the lower range and elevated levels, the orange to red colour blocks. Colour matching is made even easier by using Ames' own perforated colour charts, which are available on request and free of charge. The test is simple, quick and convenient. For greater accuracy, however, most doctors agree that meter readings provide a more objective result, and the majority of patients prefer the speed and simplicity of meters. GlucoStix reagent strips are tailor-made for use with the Ames Glucometer 2, now the world's most popular meter. The meter has three function buttons: the on-off button and the program and start buttons. The meter is switched on and a program number is then displayed. If the number does not match the program number on the GlucoStix bottle, press the program button until the numbers do match. Then prick the finger and press the start button. Use the pause to ensure you have a good drop of blood formed. At the sound of the beep, apply a large drop of blood to cover both reagent pads. At 20 seconds, a longer beep sounds. The blood is then removed from the strip by blotting with absorbent tissue. Insert the glucostick strip immediately into the strip guide behind the tab. Close the test door. The reagent pads must be facing into the meter. At the end of the countdown, 3 dashes appear, followed by a loud beep, and the result is displayed. Record the result and switch off the meter. Whether the choice is for urine or blood testing procedures, AIMS products will help your patients to maintain better control and to significantly reduce the incidence and severity of distressing complications. Currently on special offer from AIMS are Glucometer 2 Deluxe kits, which provide everything needed to begin blood glucose monitoring. Also available is a wide range of patient support and educational materials. For further information on the AIMS range of products or services, please complete and return the reply paid card provided. AIMS, the name to trust.
Ulcerative colitis is a worldwide disease, but is more common in Western countries. The annual incidence of new cases in Northwest Europe and North America can be up to 8 per 100,000 population. And it has been estimated that about 60,000 people have ulcerative colitis in the United Kingdom alone. New developments have increased interest in the management of this disease. We spoke to Professor John Leonard-Jones, consultant gastroenterologist at St Mark's Hospital.
When patients hear that they've got an illness like this, which is going to be a long-term problem, and they don't know its cause, they frequently feel very isolated. And it's at this stage that they may wish to meet some other patient who's got colitis. But it is helpful for them to come into contact with a patient association. In this country we have the National Association for Colitis and Crohn's Disease, NAC, and such organisations produce informative leaflets, and they can put the patient into touch with other patients with the disorder, and this is very helpful.
The importance of patient support is reinforced by Dr. Henry Janowitz, consultant in gastroenterology and clinical professor emeritus at the Mount Sinai Medical School in New York, and founder of the National Federation for Ileitis and Colitis.
One of the most important functions of the National Foundation for Ileitis and Colitis, as I'm sure will be for the British Foundation, is the support and help it gives the patients. It's important to free them from the isolation of their disease, to encourage them in their freer communication with their doctors, and equally important, to meet with other patients in self-help groups. This we have found to be one of the most valuable aids we can give our patients in their total support network.
As one talks to patients, naturally they express concerns about how this disease is going to affect their lifestyle in the future. Most of the patients, probably 70 to 80%, can be managed medically throughout their lives, but they will require recurrent treatment and perhaps maintenance treatment to prevent relapse. Sulfasalazine is a combination of one of the earlier sulfonamides, sulfapyridine, and 5-aminosalicylic acid. Controlled trials in the 1960s showed that this drug was useful for mild acute colitis, but its main use has been in reducing the relapse rate. The problem with sulfasalazine has been the side effects which come from mainly from the sulfonamide part of the molecule. Among these is male infertility, and this is very important when the drug is given in the long term to younger men. It was very exciting when it was discovered that the 5-aminosalicylic acid given alone seemed to be just as effective as the combined drug. And thus there's increasing interest now in using 5-aminosalicylic acid. It can be given as a delayed release preparation, and this probably reduces the relapse rate just as sulfasalazine does, and it can also be given topically as an enema to the rectum for distal colitis.
It's obligatory, I think, on us to maintain our patients on medicines which have proved in their case to work. And here, the fact that we can use 5-ASA for long periods of time, I think is a significant advance in our management of the patients. The importance of 5-ASA is to deliver it where we want it in the intestinal tract. To do that, a variety of techniques have been evolved. We can protect the 5-ASA from absorption by linking it to an inactive form, another drug, as in valsalicide, or one can link 5-ASA to another molecule of 5-ASA so that it arrives in the colon unabsorbed. We can design it to be coated in an acrylic resin which delivers the active principle at specified times as the medicine moves through the intestinal tract, or it can be designed and incorporated into a resin that liberates the drug at the appropriate biochemical milieu, at a pH of 6 or 7 as a nasocol.
When talking to patients, it is very important to be aware of their current problem and to be flexible with one's drug therapy. We are at a very encouraging moment because there are new developments in drug therapy, and as physicians we need to keep abreast of this new information.